So the patients would be excessively hungry. Their stomachs would be a bottomless pit, so to speak. I was a drug rep for Eli Lilly's neuroscience team from 1998 to 2000, and I sold olanzapine, Zyprexa. Lilly is being accused of having suppressed data regarding the side effects of the drug. I can say firsthand, as someone who had sold it, someone who had encountered a lot of these grievances from physicians, so mostly psychiatrists, we ran into uncomfortably high frequency those side effects. One side effect is the associated obesity. A lot of antipsychotics have a variety of side effects, and the big one for ours, no pun intended, was the incredible amount of weight gain that patients would get so quickly. And perhaps linked to this is associated diabetes with prolonged use of Zyprexa. When I would relay these concerns from my clients, these psychiatrists were really concerned that their patients were blimping up. We were instructed by our DMs to downplay those side effects, to focus on the efficacy of the drug, and if it was still a question of concern, we were given, I remember one particular piece of advice that almost sounds ridiculous in hindsight. We were told to recommend having the patient drink a glass of water before taking the pill and right before a meal, and then having a glass of water after a meal, or during the course of the meal, a big glass of water, in the hopes that the stomach would expand. The muscles in the stomach are connected to nerves that connect to the satiety centers in your brain that tell you when you're full. The glass is half full. I say what drug works better than our competitors. Our drug is brand new, and it's the state of the art, and it affects these receptors. And in terms of what's more important, do you want them to get better, or do you want them to stay thin? Would you rather have a thin psychotic patient or a fat, stable patient? And I put it in those contexts. Of course, I'm never so unsubtle about it to put it so bluntly, but that's the sort of framing that I have in mind. In terms of effectiveness, I mean, we go into the studies, and the studies are fantastic. But how you frame that information is very different from how that information is necessarily, or what the significance of that information necessarily is. Okay, so let's say we take a drug, and we say drug A has, in studies, it's been shown to cause insomnia in 3% of patients, whereas drug B causes insomnia in 2% of patients. If a doctor is concerned with drug A's insomnia, and I want to sell drug A, I can say, listen, there's only a 1% difference from 2% to 3%. Is that really important? No, not a big deal. But if I'm selling drug B, I can say drug B causes 50% less insomnia than drug A, and both are statistically accurate. And it's like my stats professor once told me. Statistics are like prisoners. You torture them long enough, and they'll tell you whatever you want to hear. Yeah, there are other signs. I mean, there's something called NMS, neuromalignant syndrome. Seizures, things like that would happen as well. And those are, pretty catastrophic side effects to have in your patients. But our drug was noted for having excessive weight gain associated with it. So when you think of weight gain in terms of antipsychotics, you think of our drug. And I have to say, we, as drug reps, tended to rationalize that weight gain, and tended to rationalize our giving this rather paltry piece of advice to our physicians by either assuming that weight gain was really propaganda put up by our competitors. And so we could say it with a straight face and good conscience, or at least try to. And again, this is a rationalization process, so a lot of us knew better than that. The impression I get from working at Lilly is decisions like these are simply a cost-benefit analysis. And I think somewhere up there, someone says, well, you know what? This diabetes thing, this weight gain, sure it exists. But if we start talking about it now, we're going to lose X amount of millions of dollars. Whereas if we let it slide, it might never be really noticed, or we might get in trouble for it, but it'll cost us Y millions of dollars. And X, to say it now would be financially more costly than to deal with the legal repercussions 5 years later. You see a lot of psychotic patients, and you begin to associate certain clusters of symptoms with someone as being psychotic. For example, if I see someone walking in the street and they seem to be pretty poorly, they seem disheveled, they have headphones on that's blasting music and they're chain smoking a cigarette and they look pretty fat, I instantly think, I'm guessing this guy's probably a psychotic patient. Because all those symptoms, except for that last one, are signs of psychosis. And that fatness means he's probably on an antipsychotic. And if he's particularly fat, he's probably on Zyprexa.